Okay, the next speaker in this session is going to be talking about interventions to promote physical activity in cancer survivors, and that's Bernardine Pinto.
Morning, everyone. I'm very pleased that I'm not the only the speaker between now and lunchtime. I've got something good going. So let me thank the organizing committee for inviting me, and let's get going. So my charge was to review the interventions that have been offered for cancer survivors, and a couple of caveats. I'm focusing only on adult survivors, and given my bias as a researcher, I'm going to be focusing primarily on the randomized trials. I will then continue to talk about some of the issues of actually getting patients to change their behaviors, both for adoption and the maintenance of exercise, touch briefly upon theories that have been used, and then talk about where I think we need to go, and finally end with the opportunities for exercise promotion in the healthcare of cancer patients. So I'm going to be taking the 30,000 feet viewpoint of this literature. So before I got started, I thought, let me just look to see what other people have said about this area. And I did a quick lit search only from 2013 onwards. And you can see the keywords that I used. I identified 78 papers, of which I excluded 28. There are at least 52 review papers. These are not the individual studies. These are the review papers. So I did a lot of reading. However, let me tell you, these review papers are all slightly looking at the same populations, but looking at it with slightly different lenses. So some included yoga, some included randomized trials, some didn't. But anyway, so there's a lot of work, and I just wanted you all to see, because this is a reflection on the number of studies that have been done. So there are at least 17 reviews in breast cancer patients corresponding to the number of studies. And then after that, it's the studies that have used, that have recruited patients from different cancer types. And you can see down the slide, some cancer subtypes have hardly been studied at all, okay? So areas for future work. Okay. So let's think about when these programs have been offered. 10, 15 years ago, when I got started in this line of research, there were very few studies ever offered to patients right after diagnosis, either pre-surgery or even during neoadjuvant treatments. We now have reviews of that. So there are trials. This is all very promising. But for the most part, most of the studies have been offered to patients in treatment and in the immediate post-treatment phase. Fewer studies in long-term survivorship, and very few, if none, in palliative care and end of life. So again, we have a lot in the middle of the phase of the continuum of cancer, after cancer diagnosis, but not a lot at the two ends, as Cindy also pointed out. So the early studies, this is from 1989 onwards, most of the studies, as I said, during and post-treatment, very select group of patients, because we had to be so careful about the safety issues. And therefore limited generalizability. And it wasn't always clear what the differences were between the people who took part in the studies and those that weren't. I'm going back to what I consider to perhaps one of the most comprehensive reviews of this literature, and was published in 2010. And I'm so glad that I follow other reviewers have talked about the specific studies, but by and large, during treatment, you get small to moderate effects on fitness and upper body strength. SPEC, by the way, this particular review is of about 82 trials, 77 of them are randomized, and a majority on breast cancer patients, 60% in the post-treatment phase. So just to give you a sense of when these studies were done. And when you shift to the post-treatment phase, you get larger effects, because patients are doing better, and perhaps they're likely to adhere to the program to a greater extent. We always have to keep in mind what the safety profile is of these interventions. And for a while, people weren't reporting these. Now we see a greater number of studies actually reporting them, and many reporting no harm. But we still need to keep an eye on this, especially when we start offering programs for patients who have hardly been studied before, or the programs haven't been offered to them. And we also have to think about what would be the risks for the patients if they stayed inactive. The retention of these trials is good. Better retention when the programs are offered after treatment than during. I want to spend some time talking about what settings have been used. And for the most part, the early studies were always offered on-site in hospitals, in cancer centers. And I fully recognize that there are hybrids out there, but for the most part, the studies were either on-site or they were off-site. And off-site utilized print, phone, social media, whatever. And I just want to point out what some of the key features of these programs are. When you have on-site programs, the investigators are able to conduct baseline exercise tests. They can give them a very clear exercise prescription. Most programs are around 16 weeks, combined aerobic and resistance, and usually delivered by very trained exercise physiologists or trained individuals. When you look at the off-site programs, the distance-based programs, they're never going to see those patients. So invariably, there is no baseline exercise test, but they do give them an exercise prescription. But the dose delivered is going to be not of high intensity. And the length of these programs can be anywhere between 8 weeks to a year or more, because you don't actually see the patient. So you can deliver longer programs. The staff who deliver them, that varies. Sometimes it's research staff, and in some cases there is no delivery agent because you're using the web. So it's a mixed bag. Okay, I just want to skip some of these points. Most of the on-site programs tend to be group-based, whereas if you're exercising at home, you may not be exercising with anyone, and you may be fine with that. So the on-site programs tend to be very select because you're dealing with people who can come to you, who overcome travel problems, overcome scheduling, and might like to exercise with other people, whereas the reach of off-site programs tends to be much broader. The integrity, and this has been brought up in earlier presenters, the integrity of the intervention delivery tends to be much better with on-site programs. Adherence is very closely monitored, and therefore you also get very stronger effects. But they tend to be not based on theory. Off-site programs, it depends on how closely the investigators have paid attention to how well that intervention has been implemented and how well people have actually adhered to the program. Going beyond, yes, I did exercise, I did 30 minutes, but how do you know the patient actually did that? So some method of objective method of monitoring it. So when you deliver a lower dose, you're going to get smaller effects, but these studies tend to utilize theories of behavior change to get the people to really change their behavior and hopefully to maintain it. Safety is monitored in both programs, in both types of programs, but more so on site. And we have, unfortunately, very little data, and no one has mentioned this to date, on the costs of these programs, because that has a lot to do with whether that can be implemented on a wide scale once the outcomes are firmly established. Maintenance is not frequently assessed. Oh, I'm sorry. I had to look at my slides. And the off-site programs we expect, is that okay? Thank you. The off-site programs we expect are going to be perhaps less labor-intensive, perhaps more cheaper, and perhaps maintenance would be much more well-established. Okay, so when we talk about what the theories of behavior change are, most of the on-site programs don't use any theory because they are working one-to-one, and they may not be really focusing on that. There have been certain theories that have been explored to a great extent, greater extent than others, and they're on the slide: social cognitive theory, the theory of planned behavior, and the trans-theoretical model, which thinks about how ready is the patient. And as Dr. Goodwin mentioned earlier, there are some people who are more ready to make changes than others. I just want to briefly mention the social cognitive theory, because that one has actually been studied to a greater extent. And in the trials where they have utilized the approach, you do get small to moderate effects on physical activity, but the component that seems to be really important is people's sense of confidence. Can they continue to exercise? And how have they focused on that? Very simply, as someone mentioned, use a Fitbit, use some method of logging your activity, or using a pedometer. And interestingly, the people who have higher self-efficacy or self-confidence tend to increase their physical activity faster than those with lower self-efficacy. And so getting people to feel more confident about what they're doing and teaching them the skills perhaps of how they're going to maintain it seems to play a key role. So across all those interventions, key pieces, this is not rocket science, it's very simple techniques that have worked with other populations, helping patients understand what the recommendations are, helping them to set goals, and helping them to monitor their activity. The role of social support and other techniques that are evidence-based, we have less evidence in this particular patient group. Okay. I do want to spend just a minute or two on behavior change studies, because these are the studies that actually looked at getting the patient to change the behavior. It doesn't mean that they didn't look at any of the outcomes that have been presented in the first session, but they actually focused more on changing behavior. And I think Shelley Bluterman is here somewhere in the audience, so thank you for doing that review. So most of the trials here were, again, among breast cancer patients. And they were about all well-educated white women living in metropolitan areas. Interventions were about 17 weeks long, mostly moderate intensity. And the important piece here is they were mostly home-based. And the message I want to get across to you all, perhaps more is not necessarily better. There was small effect size on physical activity. Highly structured interventions produce larger effects. But here's where the important piece is. Interventions delivered by phone or by email are also effective. So that's what we also need to keep in mind when we're thinking about how costly are these interventions. The components in these behavior change interventions, similar to what I just mentioned, self-monitoring, using some kind of counseling one-to-one with the patient, or in some cases, peer support groups. I'm very glad that Kerry spoke before me, so I don't have to go into all the details of the challenge trial. What I do want to focus on is that this intervention is a very intensive intervention. There are 17 different techniques that are being used here. There's supervised exercise, there's access to a fitness facility, there's contact with staff, there's a lot of tailoring to the person and written materials. So I consider this a Cadillac version or a Rolls-Royce, depending on which side of the pond you're on. But the reason is, and the outcome, as Kerry presented, is disease-free survival. So they want to present a very strong intervention. And this is one of the few trials, too, that's based upon a theory. Okay, so let's move on to maintenance. Once people have actually started becoming active, are they maintaining the change? And we know, based on the presentations that have preceded me, we know that maintaining activity is going to be important for management of cardiovascular disease, of diabetes, and possibly for cancer survival. It's also important if we expect people to maintain some of the psychological benefits of getting active, whether that be mood improvement or reduction in fatigue. Unfortunately, again for me, in 2013, Spark and others reviewed the literature on diet and exercise for breast cancer survivors. Why breast cancer survivors? Because those are the specific group in which most studies have been offered to that group. But very few of them actually looked at whether the behaviors are maintaining over time. And they defined maintenance fairly conservatively as at least 3 months after the last contact. And only 4 of those trials, 4 of the 63 actually, 10 of the trials assessed post-intervention outcomes, and only 4 of them actually achieved maintenance. And you can see what the outcomes were in terms of maintenance. So studies now are looking not just to get people to become active, but also help them to stay active in the long term. One of the other things we have to remember for cancer patients in particular is that they experience various effects while they're going through treatment. But there are also late effects that emerge 2-3 years later. And sometimes they may become more ready to change behavior, or it might disrupt the behaviors that they have just developed. So it's a slightly different issue as compared to other chronically ill patients. Long-term outcomes that have been mentioned, there in terms of ongoing trials, the effects on survival, the effects on all-cause mortality, and also of cardiovascular disease. Right now, they're unknown, but we would expect in about another 5 years or 8 years, we'll have some data about these long-term outcomes that are also equally, if not more important to the patients and their families. Okay, so where are we going? I just want to share what I think we are, the directions that we should develop. That we're ready sometime, in some cases, to move to the second generation of studies. I have a caveat. There's some groups that have not been studied, and we're still doing feasibility studies with some cancer subtypes. We know very clearly that one size doesn't fit all. And so what we're moving into, or what we should be moving into and are in some cases, we need to answer the question, what works for whom, under what circumstances, and for which outcomes. So we need to be thinking, regardless of how we're delivering the intervention, to what the exercise dose is, so that we can figure out then, okay, with this particular dose, we're going to get that particular outcome. And if we're thinking long-term, we also have to think about the minimal dose, because that will have immediate bearing on the feasibility of implementing these studies to reach a greater number of cancer survivors. So what's the distilled down version of that intervention? And thank you, Carrie, for presenting these data as well. The exercise dose study, this is one of the best studies looking at the dose of exercise. They didn't get differential effects between the 3 exercise arms on their main outcome, which was physical functioning. However, there were differential effects depending on what other outcomes were being looked at, whether it be endocrine symptoms or pain. There were differences between the 3 exercise arms. So here we're developing a sense of what should be the exercise dose. We need to think about programs, however, that will improve the outcomes, but also allow patients, be something that the patients can actually adhere to. Most of these cancer survivors are older patients. We have to think about what can they do. Showing them a very small screen, and believe me, my sense of aging has changed over time. It's pretty challenging when you're looking at a very small screen and very small little keys. We also need to think about pragmatic designs, and I have to applaud our colleagues in the UK, where they are thinking about interventions that are actually can be implemented in their healthcare system. So here's an example that I have on the slide. It's 1 in-person session and 3 phone calls. Okay, so they're thinking ahead, because sometimes the intensive interventions, though they work, may not be something that can be offered to many patients. Okay, the question about when to intervene, when's the optimal time for patients and their family members? I've already shared with you all that most of the trials have been done during and post-treatment. It also depends upon what outcomes are you expecting to achieve. So when the intervention is offered soon after diagnosis, the goal is to help to improve the patient's post-surgery recovery or improve aerobic capacity. On the other hand, if you want to offer an exercise program for somebody in palliative care or end of life, perhaps what your goals are going to be is help to reduce symptom burden or improve quality of life. So there is a place in this continuum for exercise interventions, but the outcomes are going to be different. So I know that Wendy asked this question many years ago, so is there a teachable moment? I don't think there is a moment. I think there are phases, and there are going to be times when the readiness, the teachable moment expands and people are receptive, and sometimes they are less so. I particularly think that when late effects emerge, even if a patient wasn't ready during the treatment or even in the post-treatment phase, they might become ready at a later time. For whom should these studies be offered? Among breast and prostate cancer patients who have been studied, there are groups that haven't been reached. I'm really glad to hear that there are studies now for patients in rural settings and also patients who are minorities. There are some prevalent cancer subtypes who have not been included, or there are very few trials. But I think we need to think about getting to the patients who actually have the problem. So if you want to impact fatigue, this has been mentioned before, we need to find the patients who are actually reporting that particular problem and then determine what works for which group of patients. Some of the trials that have been done show that people who are obese tend to benefit more from exercise interventions than perhaps patients who are more fit. Those are the directions in which we're heading so that we can fine-tune our interventions for specific groups. We need to be thinking about what the mechanisms are, whether they be biological mechanisms, especially when we're looking at the link between exercise and cancer. Is it working through an insulin pathway? Is it through the immune functioning? Which biological pathway? If, on the other hand, we're looking at exercise impacting quality of life or fatigue, maybe it's something completely different. Maybe it's because of the behavior change or the improvement in fitness. So the mechanisms might be different as well. Okay, so what have we learned from working with our patients in terms of actually getting them to become active? The important element is to tailor to their needs. A patient who has had a lumpectomy is experiencing very different symptoms than someone who has gone through a stem cell transplant. So they can't all be offered the same type of intervention. We've talked about aging as age is another factor. We need to offer interventions that actually have relevance to the outcomes that are meaningful for our patients. And once we get those data, then hopefully it will facilitate reimbursement for our programs. Our patients want programs that will provide them meaningful goals, help them be independent. So we need to listen to our patients as well. Our patients have strengths, and sometimes we forget that. There's a lot of data out there on what patients prefer. They want some choice and flexibility. And I just want to put a little plug out for cultural tailoring. I know that Karen and her group have done some work with Latino cancer survivors. I really like the work that's been done in Europe. They are offering football clubs for prostate cancer survivors, going back to their glory days of playing football. And instead of having to sit around a table and talk about the problem, it appeals, and it also has cultural relevance to them. Nordic walking, I believe, will not have much of an appeal in the southeast where I live, but more in Scandinavia. Okay, we need to think about the barriers that our patients face. And I've mentioned aging before. Their anxieties and fears about cancer, but their anxieties and fears about exercise as well. There are patients who say, I would prefer to be in an on-site facility where somebody is watching me, and we need to pay attention to that. And of course, the usual barriers that all of us encounter. My wish list, when we do trials, let's try to achieve those of high quality where we are describing what our interventions are really in detail, who the delivery agents were, and we won't be able to do double-blind studies, but maybe at least have our assessor blind to the randomization status. We're also always going to be in this rub between strong effects and feasible studies. And I think that's where our challenge continues to lie. I'd like us to think about using theories of behavior change and utilizing the technology that is available, keeping in mind that most of our survivors are older adults, but social media and other telehealth, et cetera, may be very appealing to young adult survivors. Facebook has been used for that. And the other elements about costs, we need to keep an eye on that if we expect these interventions to be rolled out, and safety and maintenance. Okay, I want to just end with my perspective on exercise in the healthcare continuum. I consider this as an area where there are multiple missed opportunities at the different points after diagnosis. It's not part of our treatment plans or our survivorship plans. We know that our oncologists in particular are very reluctant to prescribe exercise for lack of training and skills, but we have had programs and interventions that we have implemented in the healthcare setting. We need to scale those up. And of course, there is no prioritization of exercise in the healthcare setting, particularly related to reimbursement issues. But our providers, be they a physician or a nurse practitioner or a PCP, they need some guidance on how to triage patient. Does the patient need physical therapy? Does the patient need an on-site program because they have comorbidities? Or will they be fine in a community-based program? Or eventually in a distance-based program? And the same is true when patients transition back to their PCPs. There are lots of opportunities for them to talk to their patients, but they also need to be aware of late effects. And when they make those and have the resources that they can refer patients to when there are problems. And I would just urge us all to find suitable dance partners. We need to scale up our interventions. There are community programs out there, as long as they are safe and effective, and also partner with patient advocacy groups as well. I will end there. I know Pakistawani Phil said another 6 weeks of winter, but where I come from, we already have some signs of spring. And I just want to end with a humorous note. Thank you.